1 in 4. That is the statistic. 1 in 4 adults over the age of 65 falls at least once every year in the United States. That is not a rare event. That is not something that happens to other people, to frailer people, to older people than you. 1 in 4, which means that in a room of 4 people over 65, statistically, one of them will fall this year. And yet, despite how common falls are, despite how serious the consequences can be, most adults over 65 have never had a formal fall risk assessment. Most have never been asked by their doctor the specific questions that would identify whether they are at elevated risk. Most have never had the specific physical tests that measure the functions most directly linked to fall risk. And most have never been connected to the programs and interventions that research has shown meaningfully reduce the likelihood of a fall. I am Dr. Daniel Chen, and today I want to explain what a real fall risk assessment actually looks at. Not a quick question at the end of an appointment, but a thorough evidence-based evaluation of the specific factors that genuinely predict whether someone is likely to fall. Because understanding what those factors are is the first step toward addressing them. And because falls are not simply random events that happen without warning and cannot be prevented, they are events with identifiable risk factors that can be assessed, measured, and in many cases, meaningfully reduced. So let us start with why falls matter so much. Beyond the fall itself, a fall that results in no injury is frightening and often leads to a fear of falling. That itself reduces activity and paradoxically increases fall risk further by reducing the strength and balance that activity maintains. A fall that results in a soft tissue injury, a bruise, a sprain, a muscle strain, causes pain and disability that can limit activity for weeks and again, reduce the conditioning that protects against future falls. And a fall that results in a fracture, particularly a hip fracture, is a genuinely life-changing event for many older adults. Hip fractures in adults over 65 are associated with significant rates of permanent loss of independence, long-term care placement, and mortality. Research has consistently shown that a substantial proportion of adults who fracture a hip after 65 do not return to their previous level of function within a year, and that the 1-year mortality rate following a hip fracture in adults over 65 is significant. Falls are the leading cause of injury and injury death in adults over 65 in the United States. According to the Centers for Disease Control and Prevention, this is not a minor public health concern. It is one of the most serious and most preventable. Now let me explain what a real fall risk assessment actually evaluates, because most people assume that fall risk is simply about whether you have fallen before or whether you feel steady on your feet. But a thorough fall risk assessment is much more comprehensive than that. It evaluates multiple domains, each of which independently and in combination contributes to the likelihood of a future fall. The first domain is fall history. Has the person fallen in the past year? How many times? Under what circumstances? Were they indoors or outdoors? Were they doing something specific? Or did the fall happen without obvious cause? Did they lose consciousness before falling or hit their head during the fall? These details are important because the circumstances of a previous fall often reveal the mechanism and therefore the specific risk factors that need to be addressed. A fall that happened while turning quickly suggests a balance or vestibular issue. A fall that happened immediately on standing suggests orthostatic hypotension. A fall that happened while walking without any obvious trigger suggests gait instability or muscle weakness. And a fall preceded by dizziness or a brief sensation of losing consciousness requires cardiac and neurological evaluation to rule out more serious underlying causes. The second domain is gait and balance assessment. This is the physical examination component of fall risk evaluation, and it uses several validated clinical tools that have been specifically developed and extensively tested for this purpose. The most widely used is the timed up and go test or tool. In this test, the person sits in a standard chair with arms. They are asked to stand up, walk 3 meters, turn around, walk back, and sit down again. The time this takes is measured. Research has established that adults over 65 who take longer than 12 seconds to complete this test are at significantly elevated risk of falls. The 2UG test assesses multiple components simultaneously. The ability to rise from a chair, which requires adequate leg strength, walking speed, and steadiness. The ability to turn, which requires vestibular function and coordination. And the ability to sit back down safely, which requires controlled eccentric leg muscle function. A slow or unsteady 2UG performance immediately flags specific areas for further assessment. The second widely used balance assessment tool is the Berg balance scale, which assesses 14 different functional balance tasks, including standing with feet together, standing on one leg, reaching forward while standing, turning to look behind, and stepping up onto a step. Each task is scored, and the total score identifies the level of fall risk from low risk to high risk, requiring intervention. The 4-stage balance test, used in the CDC's study program, assesses the ability to hold progressively more challenging standing positions, side-by-side feet, semi-tandem stance, and single-leg stance, each held for 10 seconds. The stage at which a person can no longer maintain the position for the required time indicates the level of balance impairment and the specific type of balance training most needed. The 30-second chair stand test counts how many times a person can stand up and sit back down in 30 seconds without using their arms. This test specifically measures lower extremity muscle strength and endurance, both of which are critical for maintaining stability during daily activities, including stair use, getting in and out of vehicles, and recovering from a stumble before it becomes a fall. The third domain is vision assessment. Vision is one of the 3 main sensory systems that your brain uses to maintain balance. The other 2 being the vestibular system in the inner ear and proprioception, the sense of position coming from muscles and joints. When vision is impaired, the brain has to rely more heavily on the other 2 systems to maintain balance. And if those systems are also affected by age, as they commonly are, the loss of clear vision places a disproportionate burden on an already challenged balance system. Research has specifically linked visual impairment, including reduced contrast sensitivity, reduced depth perception, and uncorrected refractive error, to increased fall risk in older adults. And the CDC identifies annual eye examinations and timely correction of visual impairment as a specific evidence-based fall prevention strategy. A fall risk assessment should include a review of when the person last had an eye examination, whether they are wearing glasses or contacts, with an up-to-date prescription, and whether they have any known eye conditions such as glaucoma, cataracts, or macular degeneration that are affecting their functional vision. The fourth domain is medication review. Medications are one of the most important and most modifiable risk factors for falls in older adults. Multiple classes of commonly prescribed medications in this age group directly affect the systems that maintain balance and stability. Sedating medications, including benzodiazepines, sleep aids, and certain antihistamines, reduce alertness and reaction time, making it harder to respond quickly to a stumble or loss of balance before it becomes a fall. Blood pressure medications, particularly if they are producing orthostatic hypotension, as I discussed in a previous video, can cause dizziness and instability. In the seconds after standing, diuretics increase urination, and in older adults who rush to get to the bathroom, particularly at night, create a fall risk. In the nocturnal period, when lighting is poor, alertness is reduced, and stability is at its lowest. Alpha blockers used for enlarged prostate or blood pressure can cause orthostatic hypotension and dizziness. Anticholinergic medications, including some antidepressants, some bladder medications, and some antihistamines, can cause confusion and impaired coordination. That increases fall risk, and polypharmacy itself, taking 5 or more medications simultaneously, is an independent risk factor for falls, regardless of which specific medications are involved, because the combined effect of multiple drugs on alertness, blood pressure, and coordination is often greater than the effect of any individual medication. Considered in isolation, a fall risk assessment should include a comprehensive medication review, conducted by either the doctor or a pharmacist, looking specifically for medications that are known fall risk contributors, and whether dose adjustment, timing change, or substitution might reduce that risk without compromising the treatment for which the medication was prescribed. The fifth domain is home environment assessment. The majority of falls in older adults occur in the home rather than outdoors, and research has identified specific environmental features that significantly increase fall risk. These include poor lighting, particularly in hallways, bathrooms, and on stairs, loose rugs or mats that can slip or catch a foot, absence of grab rails in the bathroom, around the toilet and shower or bath, absence of stair rails, or rails that are inadequate or on only one side, clutter on walking surfaces, including items on the floor that must be navigated around, inappropriate footwear, including slippers without backs, shoes without adequate grip, or walking barefoot on smooth floors, pets, particularly dogs and cats, that move unexpectedly into a person's path, bathroom hazards, including wet or slippery floors, and a bath or shower without non-slip surfaces, and steps or thresholds between rooms that are not clearly visible or adequately illuminated. An occupational therapist is the clinical specialist in home environment assessment and modification, and a referral to an occupational therapist for a home safety assessment is one of the most evidence-based fall prevention interventions available to older adults. Research has shown that home modification programs conducted with high-risk older adults by occupational therapists reduce fall rates significantly in the population studied. The sixth domain is assessment of specific medical conditions that independently increase fall risk. Several common conditions in adults over 65 are well-established fall risk factors in their own right. Parkinson's disease affects gait, balance, and postural reflexes in ways that substantially increase the risk of falls, requiring specialized assessment and management. Peripheral neuropathy, which affects sensation in the feet and legs, reduces proprioceptive input, the sense of where the feet are and how the surface feels, that the brain relies on for balance, and which is significantly more common in adults over 70, including those without diabetes. As I discussed in a previous video, cognitive impairment affects the executive functions, including attention, judgment, and the ability to divide attention between a cognitive task and maintaining balance that are critical for safe navigation of real-world environments. Vestibular dysfunction, affecting the inner ear balance organs, causes dizziness and unsteadiness that can occur with specific head movements or with changes in position, and which is specifically accessible and treatable through a form of physical therapy called vestibular rehabilitation. Urinary urgency, which causes older adults to move quickly, particularly at night, when conditions are least safe toward the bathroom, is a recognized and often overlooked fall risk factor that deserves specific clinical attention. Foot problems, including bunions, calluses, toe deformities, and reduced sensation, affect the stability and safety of the base of support that balance relies on, and depression, which affects motivation, activity levels, and in some cases is treated with medications that independently affect balance, is an often missed contributor to fall risk in older adults. The seventh domain is assessment of fear of falling. Fear of falling is not simply a psychological response to having fallen before. It is a clinically recognized and clinically significant condition that affects a substantial proportion of older adults, including many who have never fallen. Fear of falling causes people to restrict their activity, to avoid situations they perceive as risky, to walk more tentatively and stiffly, and to lose the confidence in their physical capability that supports safe and stable movement. This activity restriction leads to muscle weakness, reduced cardiovascular fitness, social isolation, and paradoxically, reduced balance and strength that increase the very risk that the person was trying to reduce. Fear of falling is assessed through validated questionnaires, including the Falls Efficacy Scale and the Activity-Specific Balance Confidence Scale, and it is addressed through targeted programs that combine exercise with cognitive and psychological components to rebuild confidence in physical capability, alongside genuine improvements in the underlying strength and balance that make that confidence well-founded. Now let me explain what a fall risk assessment looks like in practice and who should be doing it. The CDC's STEADY initiative, Stopping Elderly Accidents, Deaths, and Injuries, is a free, evidence-based clinical program designed specifically for primary care. It provides doctors and other healthcare providers with standardized tools for fall risk screening, assessment, and intervention, including the 3 key screening questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? Are you worried about falling? A positive answer to any of these triggers a more detailed assessment using the validated physical tools I described, the TUG test, the 4-stage balance test, the chair stand test, to physical therapy, occupational therapy, ophthalmology, or other specialists based on what the assessment reveals. This is not a complicated or time-consuming assessment. The 2G test takes less than 2 minutes. The 4-stage balance test takes less than 5. And the information they provide about a person's fall risk is clinically significant and directly actionable if you are over 65 and you have not been asked these screening questions or had these physical tests performed at a recent appointment. I encourage you to ask for them. You can say, I would like to discuss my fall risk. I understand there is a CDC program called STEADY that recommends certain assessments for adults my age. Can we go through those today? That is a completely reasonable and clinically appropriate request, and one that a doctor familiar with STEADY will recognize immediately and respond to. Let me bring everything together for you now. 1 in 4 adults over 65 falls every year. Falls are the leading cause of injury and injury death in this age group. They are not random events. They have identifiable risk factors that can be assessed and addressed. A real fall risk assessment evaluates 7 domains: fall history, gait, and balance, using validated clinical tools, including the TUG test, the Berg balance scale, the 4-stage balance test, and the chair stand test. Vision, medications, home environment, specific medical conditions, including neuropathy, vestibular dysfunction, cognitive impairment, Parkinson's disease, and urinary urgency, and fear of falling, which is itself a clinically significant fall risk factor. The CDC's STEADY program provides standardized tools for this assessment in primary care and is available to any adult over 65 who asks for it. If you have not had a fall risk assessment, please ask for one, not because you are about to fall, but because knowing your specific risk factors is the only way to address them before a fall happens rather than after. I am Dr. Daniel Chen. If this video helped you understand what fall risk assessment really means and what you can ask for, please share it with someone over 65 who has never had this conversation with their doctor. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me whether you have ever had a formal fall risk assessment and whether your doctor has asked you the 3 STEADY screening questions. I read every single comment, and I genuinely look forward to hearing from you. Take care of yourself. A fall can change everything. Knowing your risk and addressing it before that happens is one of the most important things you can do for your independence and your health.